Today's speaker is near and dear to my heart, as he is one of our attendings at the Lahey Clinic. Dr. David Kleiman is a staff surgeon at Lahey Hospital, and he completed his BA and MD as a combined program at Rutgers. He did his surgery residency at New York Presbyterian Cornell and a fellowship at Memorial Sloan Kettering. He joined the staff at Lahey at 2017 and currently serves as director of robotic colorectal surgery and program director of the NAPRC initiative. He's a very active member of ASCRS, and some of you may know him as vice chair for Young Surgeons Committee and a member of the Engagement Committee and Young Researchers Foundation. He is going to be talking tonight with us about how to tame your colonoscope and make it your new best friend. So with that, we'll let you take it away, Dr. Kleiman, and I'll remind everybody who's logging in to please mute as you log in and go ahead and unshare screen just for streaming purposes. Thank you.
Awesome. All right, great. Thank you very much, Dr. Dombeck. I'm going to go ahead and share my screen here. All right, looks like that's showing up. All right, good evening, everybody. First of all, it's a pleasure to be here. Thank you so much to Gabby and the whole rest of the virtual education series for inviting me back. It's a true honor to be here. This is a fantastic series. We're really lucky to have this in our field. And just as Gabby said, I'm near and dear to her heart. She and this whole series are near and dear to my heart. This was started by one of my good friends and partners, John Abelson, and his colleagues his year at the start of the pandemic. And then one of our other former fellows, Tessa Olet, took the reins the year after. And now Gabby is continuing the tradition of involvement with the planning committee here. So I'm proud of what this series has been able to do and the people that we've had a part in helping to train along the way. So it's great to be back here this year. Thank you for the invitation. We're going to talk about something tonight that is very important to my practice, which is colonoscopy. Colonoscopy is it's important to all of us in colorectal, some more than others, depending on your practice situation and your personal comfort zone. But regardless, I think there's a lot that we should all be talking about in terms of how we're teaching colonoscopy. The origin of this came back to me from my fellowship, and I wasn't a fellow all that long ago, and I can very, very vividly remember the frustration that I felt as a fellow about colonoscopy. And the frustration was partly because I felt like I just wasn't very good at it. And why wasn't I good at it? Why wasn't this something that I should just be able to just do, right? Why couldn't I just be born knowing how to do this? And then also I felt like the way that it was being taught really was mostly just a bunch of my mentors just kind of being like, oh, just stay at it. Just keep trying, you'll get it. But not really telling me exactly what I should be doing to do better. And then towards the end of my fellowship, I worked with an attending who, for the first time, really kind of started breaking it down in a systematic way. And then all of a sudden, with just a few months left in fellowship, things kind of fell into place, and I suddenly started to get it. And that's what inspired this. And from there, over the last 6 or 6.5 years of my practice, I've sort of built upon that system, and that's going to result in what I'm going to share with you tonight. So hopefully some of these things can work for you. And then if it leaves you with more questions than answers, feel free to reach out to me afterwards. Send me an email, or you can find me on the ASCRS website or whatever. Grab me at the meeting. Be happy to talk to anyone more about this stuff. Okay, so what are we going to do tonight? So first, we're just going to talk about defining the problem, and then we'll just dig into why is colonoscopy so darn hard? I mean, let's be honest, it is not easy, and why is that? And then I'm going to share with you what I call the difficult colonoscopy toolbox and all the different tools that I use to handle these colonoscopies. And finally, we're going to talk about actually how do you incorporate this into your practice, and what can you do to take better care of your patients with the use of a colonoscope. Okay, so first, define the problem. So a couple of scenarios just to kind of get your brain spinning in the right direction. And these are real life scenarios from my practice that just demonstrate the importance of colonoscopy. So this is a 65-year-old woman who had a positive Cologuard. Your favorite local gastroenterologist performed her colonoscopy, found invasive cancer. And they told you that it is, quote, just distal to the splenic flexure at 65 centimeters. Right off the bat, that scares me because that lesion can be anywhere from the hepatic flexure to the distal sigmoid. You really don't know where that's going to be. But this comes from someone you know and trust. So is it really just distal splenic flexure? They tattooed it for you. And so you plan to do a laparoscopic left colectomy, and you get this case going, you put in your ports, and you're looking around and you can't see the tattoo. So you put in a couple more ports and you start mobilizing. Oh, it must be underneath the omentum. And you do more and more, and you still can't find the tattoo. What do you do? How about this patient, a 54-year-old with a history of quote unquote colitis, found 25 years ago, now in remission. Had a colonoscopy that found moderate inflammation beginning at 55 centimeters from the anus and extending to the cecum. And then they found a 5-centimeter adenocarcinoma in the cecum. The sigmoid and colon were reportedly normal, and her scan had no metastases. So just start thinking, what surgery would you offer? I think most of us would be thinking along the lines of maybe a subtotal colectomy here, maybe a total colectomy, I'm not sure. But if you're not going to do a total proctocolectomy, how do you know where to divide distally? And how are you going to assess whether the colon is actually normal or where that inflammation begins? Finally, what if you do routine colonoscopies and you have a 67-year-old with chronic kidney disease, never had a colonoscopy before, but started to notice blood in his stool? Urgent colonoscopy was put on your schedule, and during the colonoscopy, you find a bunch of polyps. You find a big 5-centimeter polyp in the rectum, 3-centimeter polyp in the mid-transverse, 2-centimeter in the proximal transverse, and a 15-millimeter sessile polyp in the cecum. All of them look benign. None of them look like cancer. What are you going to do? Who are you going to refer that patient to? So here's some questions to ask yourself. How would you manage those 3 patients that I just told you if you had unrestricted access to a colonoscope, both before surgery, during surgery, and afterwards? And what if you didn't? What if you didn't have access to a colonoscope in the OR or in your clinic? How would you have managed it differently based on whether or not you could scope the patient yourself? How often do you need to call GI for a colonoscopy? Whether you're in the OR, has anyone ever called GI to the operating room to do an intraoperative colonoscopy? Have you ever had to ask your gastroenterologist to do a colonoscopy and tell you where the colon starts to become normal so that you know where to cut? How often are you relying on what they're telling you, not what you're telling yourself? And what if you did have unlimited access to a colonoscope? What are you comfortable doing? Would anyone be comfortable doing advanced EMR of that 5-centimeter rectal polyp or that 3-centimeter transverse polyp? Is anyone comfortable doing that in their practice? Or would you be referring them to GI to do an advanced interventional scope? Or would you just go straight to surgery and do a total proctocolectomy because, you know, those procedures are hard and you don't have access to someone who's willing to do that? So what's holding you back? If the answer isn't, sure, I can handle all this myself and I have scopes, what aspect of these things is getting in your way? Is it access? Is it ability? Is it comfort or training? These are just some things to think about as we go through these next handful of slides and think about this. Okay, so let's talk about why colonoscopy is so darn hard. So warning, colonoscopy is not easy. It's hard for everybody. And anyone who believes that they figured this out and have cracked the code so that they never struggle with a colonoscopy either doesn't really do that many colonoscopies or they're just lying to you, because every single one of us has done these colonoscopies that even when we're feeling good about ourselves, they're still hard. I still, I've done maybe 3,000 colonoscopies in my practice or more. I still occasionally can't get to the cecum, and you have to know when to admit defeat. So we all run into these scopes that are just really hard to do. There is no secret sauce here. There's no magic solution that's going to make all this seem easy. But what there is a systematic approach. I view colonoscopy like a puzzle, and you just got to find the right combination of pieces to make that puzzle all come together. And if you learn the systematic approach and way of thinking, your likelihood of success is going to be going to go up, and the number of cases that feel hard to you is going to start going down. So what are the things that makes a colonoscopy hard? Some of these are pretty obvious to us. So a tortuous colon, that's probably the number one most common reason that colonoscopies get difficult. These colons that just go on forever and take all these super sharp turns. But not just tortuous colons. Sometimes you have to think about restricted mobility. Think about the actual diseases to the colon that we as surgeons see all the time and take out. Gastroenterologists don't necessarily think about that. And they just kind of say like, oh, I don't know why I couldn't get through the sigmoid or I couldn't get through this stricture. But we know that there are things that make the colon really hard and fibrotic, and that might be very hard to get through. These are things like chronic diverticular disease, previous pelvic surgery, previous pelvic radiation. These are things that can make it very, very difficult to get through. Inadequate sedation. You may have a patient that's a little fond of their beers on the weekends or during the week, might make it hard to keep them comfortable. Or their comorbidities. Maybe someone who has severe sleep apnea. Maybe someone who has a BMI of, over 50. Maybe someone has COPD and then they start dropping their sats as soon as they get sedated. These are all things that can make your day difficult in the endoscopy suite. So in order to be successful, you really want to set yourself up for success. And to set yourself up for success, you have to think about three choices. You have to choose the right scope, you have to have the right type of sedation, and you have to have the patient in the proper position. And those are the three choices that you as the endoscopist really need to decide when you're doing your case to make sure that you're set up the way you want to be set up. So let's just talk a little bit about choice of scope. So, most of us have access to either an adult scope or a pediatric scope. So for me, I rarely use an adult scope. I'll take an adult scope if I don't really have a choice, or if they give it to me, I won't make them open another one. But usually I'll keep that for your average or your obese male patient. But really my preference is a pediatric scope, because to me it feels kind of like a sports car versus like a big SUV. You could just do more with it. You can make tighter turns. You can get in tighter spaces. It's a little bit more versatile. But where it's really important, I think, is if your patient's very, very thin, both male or female. If they're very elderly, they're more likely to have tortuous, gnarly colons with more, chronic diverticular disease that you may or may not know about. Any female patient, no matter what their body habitus is, I prefer a pediatric scope. And if they've had any previous diverticulitis, I've pushed adult scopes through way too many gnarly sigmoid colons. Now I know if I know they have a history of diverticulitis, I'll ask for a pediatric scope. There may be some specialty scopes that are useful to have on hand, but I'll tell you, I very, very rarely use the first two, really. There are these ultra-thin scopes, or sometimes you'll try to use a gastroscope or even a pediatric gastroscope, which is really just the size of a little bit bigger than a straw. I once asked for it, not knowing how small it was going to be. You really can't do much with that scope. So that was a lesson learned for me. And then the stuff that we use for more advanced procedures, double channel colonoscope is something that we at Lahey use all the time to do advanced EMRs. And then a scope with variable stiffness is a very, very useful tool to have. Hopefully all your scopes enable you to stiffen the scope. Choice of sedation. So we have a choice between moderate sedation or MAC, which is propofol. Not everyone has this choice. I think where I trained, it was almost exclusively propofol for everybody. And I was a little surprised when I started working at Lahey that we do about 70% of our procedures under moderate sedation with Versed and fentanyl, and only about 30% of our procedures are with propofol. So we have to be selective with who we request propofol for. The advantage of moderate sedation, I mean, people are freaking out right now because Blue Cross Blue Shield threatened to take away coverage for propofol, and there's been a lot of mainstream media attention to this recently, but I think a lot of it's not really warranted, because honestly, I prefer moderate sedation actually over propofol in many cases. It's cheaper, it's easier to schedule. It's also easier to get your patient to help you during the procedure by changing position. But the downside is it's more uncomfortable, and if you have a patient, not everyone's going to tolerate that way. If they have a very high narcotic or benzo threshold, if they are a drinker, moderate's not going to go very well. Prop is definitely better for your difficult colonoscopies. If I know a scope's going to be difficult for any of the reasons I mentioned before, then those are the ones that you want to request propofol for. Choice of patient position. So basically, everybody starts left lateral when you're in the endo unit. We do a ton of colonoscopies intraoperatively, which means those patients are usually supine in either supine split leg or lithotomy. That's a much harder position to scope in. And I say that all the time when our residents or fellows may be having a hard time. It's a lot harder to scope in a split leg or lithotomy position because you have nowhere to rest that colonoscope on the bed. So that's a more challenging position. Left lateral is the way to start. I very often will move the patient to supine, especially after I reach the splenic flexure. I'll come back to that more in a few minutes. And then think about going prone if you're really having trouble. This is something that Dave Schetz used to do all the time. And so a lot of Lahey trained people might do this more often because they learned it from him. I rarely do it, but I have done it before when I'm stuck in the ascending colon. It actually works really well. and we'll come back to that in a little bit. Okay, so now let's go into the part of this talk where we really talk about specifics. This is where I really break down colonoscopy part by part to give you some concrete tips of how to get to the cecum when you're stuck. So I've come up with something that I refer to as my difficult colonoscopy toolbox. This is your list of tools, or, my kids are really into superheroes, so I think about my Batman utility belt. These are all the different tools on your tool belt that you want to know how to take out at the appropriate time. And sometimes you got to try a number of tools before you find the one that works. It's like finding the right size screwdriver or ratchet to do the job that you need to get done. And these are the things that we're going to talk about. And again, it's using the right tool at the right time and knowing when to pull that tool out that's going to help you. So we're going to talk about things like alpha turns, unpretzeling, stiffness, the inchworm maneuver, which a lot of you are probably saying, what the heck is that? It's a Kleiman original, the hook and pull maneuver, and then pressure, which is down at the bottom of my list because I don't do it very often, but we'll talk about that, and then position changes. All right, so let's talk about this. So if you look at the upper right of the screen, I've highlighted which part of the colon we're talking about. So in different parts of the colon, you're going to have different problems, and the different problems are going to have different solutions to get you through there. So the first problem that you're often going to encounter as you're trying to get through the sigmoid into the descending colon is torsion and looping of the colon. As that scope gets through the sigmoid colon, it's going to go in sort of this corkscrew pattern. That's just the natural curve of the sigmoid. Even if the sigmoid's not particularly redundant, it still makes that shape. If it's a very redundant sigmoid, it's going to be exaggerated. When you come out the other side, as this diagram shows, the scope is going to be twisted in a corkscrew, and you have to undo that if you want to get your scope straight again. So to help demonstrate that, I'm going to try this. I've never done this before on Zoom. I hope it works. So I brought a little prop with me. Some of you with young kids might recognize this as from the Marvel I Can Do It adventure game. This is for some prop for that, but I think it kind of works as a good prop for a colonoscope. So as you go through the sigmoid and you push in like this, the scope's going to twist in a loop like that. As it loops like this, as you come out the other side, you're going to want to straighten that out. And you have to turn clockwise and pull back in order to straighten it. Why do you have to turn clockwise? Well, look what happens if I just pull back. If all you do is pull back, then this stays in this corkscrew shape. And if you don't undo the corkscrew, look at what happens as I let go of my right hand. The scope will automatically want to rotate clockwise in order to get straight again. So that's why if you have a loop, it's not just pull back, it's alpha turn, clockwise rotate, pull back, and it's going to get that scope straight faster. So the first thing that I do once I get through the sigmoid colon, and I know I'm through the sigmoid colon when the colon looks like it does here on the bottom left, if you've got that straight shot, you're looking up the descending colon. So you know you've made it through the sigmoid. Congratulations, pat yourself on the back. You made it through. Now you're staring down at the descending colon. The first thing I'm going to want to do is untwist or unpretzel that scope, because the scope's going to be in this configuration like it's drawn here, and you want to straighten that out. You may want to consider adding stiffness as well, because that'll help you advance and minimize the risk of this re-looping as you push forward. And this is where I say this over and over. Gabby has heard me say this many times. A straight scope is a happy scope. You know, the scope is not going to behave itself if it's not straight. So you always want to be working to get your colonoscope back to a straight orientation. And the first way to mess that up for yourself is to not undo the corking or the pretzeling that occurred as you were getting through the sigmoid colon. So please remember to do that. The second concept to keep in mind, especially as you're going through, well, really any part of the colon, is when I say think like a truck driver. What do I mean by that? A truck driver is sitting in the front of their cab. They're not just thinking about what's right in front of them. They have to think about the position of the entire body of their truck. Otherwise, they're going to smash into things when they're making turns. A novice endoscopist is only thinking about what their right hand is doing and what their eyes are seeing. They're completely forgetting about everything in between the eyes of what they see on the screen and what their hand is doing. In between their eyes and their hand is this black box of the abdomen where the novice has no concept of, it doesn't even know to try to think about what orientation the scope is inside the body. I'm always trying to figure that out. I'm always trying to think, is my scope straight? Do I have a loop? Do I have a corkscrew? What is going on? Why is it so hard? It should not be hard to move the dials. It should not be hard to move the scope. If it is, something's going on in that black box part that you can't see. And it's up to you to make adjustments to figure out if you can undo it. Okay, so now we've gotten through the descending colon. We've gotten around the splenic flexure. Now we're looking at the transverse colon. So sometimes you can just, that was out of order. Sometimes you can just tap on the suction a little bit, which I recommend you always do. As soon as you turn that corner of the splenic flexure and you see that nice triangular view where you know you're looking at the transverse, the first thing I do before I do anything is I tap, 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 tap the suction, because you want to decompress all that overinflation that went around the corner when you weren't seeing it. It'll be much, much easier for you to push through if the colon's just a little bit decompressed. It doesn't have to be flat, but you don't want it overinflated either. So sometimes you can just decompress, push, and go, and it'll cooperate. But more often, you're going to have some trouble here. So the tools that I use in the transverse are a little different than the tools that I use in the descending. So one thing you can do is move to the supine position. And by moving to a supine position, it allows you to push across the abdomen, not up into it, or it allows you to use gravity as your friend. And this is just a cartoon drawing of the difference here. You're not trying to go upstream with the patient on their side. You're letting it sort of just fall across. So this is a good time, if you're having a little trouble, to say, can we move the patient on their back, please? And then just have them rotate on their back. And sometimes, boom, the scope just wants to go across in that situation. Stiffness can, again, be your friend here. I'm a big fan of adding stiffness if you're having trouble in this spot. And this might be a time to ask for pressure. I have another slide specifically on pressure in just a little bit, but this is where I might ask for sigmoid pressure to help you propel through the transverse colon. But really, my favorite trick here in the transverse is something that I call the inchworm. So the inchworm is something that's probably new to anyone except maybe Gabby or anyone who's trained with me recently. The inchworm is what I visualize the scope doing as I'm crossing the transverse colon into the ascending colon. So what you do is you push in, and what you're going to feel is the scope's going to flex a little bit. I'm going to go back to my my little prop here. So you're pushing in with this hand, but if the transverse is very redundant, you're not going to get that one-to-one advancement of the scope. You might get this flex happening here. So you might not move, and you might get the sense that there's some added stiffness being added as this is going forward. If you don't push, if you keep pushing and it keeps happening, what you're going to get is a loop. We're not talking about the loop. What we're talking about is that you're getting a little bit of resistance until this lateral force starts pushing up against a combination of the colon wall and the abdominal wall. And then the abdominal wall is going to start pushing back, and you're going to start to feel resistance. What you want to do then is stop right at the apex of that, pressure, right when you feel it reach its max, just pause. And if you pause there, what you might notice is that the scope's almost starting to want to go forward. Then what you do is you undo this flex by doing what I said before, clockwise rotate and withdraw. And what's going to happen is the inchworm's going to flatten itself out, and it's going to advance the way an inchworm crawls across a branch. Now, you can almost see it happen here, or at least I did when I was practicing before. When I push it like this, if I loosen my left hand and I undo this tension, it just pushes itself forward. And that's how you're going to get the scope to accelerate. So if you don't believe me, just try this. But it's a feel thing, and it's a little hard to feel the difference between a flex and a loop. A loop would feel like you're pushing in and there's no resistance. You're just pushing in, you're not going anywhere, you're just feeding more and more in, you're looped. It's not going to work. But if you push in and you start to feel it push back against you, just wait, just sit there, and then slowly bring it back and see if you can get it to advance forward. It's a really, really helpful trick once you get the hang of it. This is also when oftentimes this is going to happen without you noticing it. If you're ever feeling like the scope is suddenly smushed up against the wall of the colon, pull back, okay? This is something that was repeated to me by my mentors over and over in fellowship. You can't see, pull back. If you can't see, pull back. But I never really understood why, and now I do. If you can't see, it's because the colon has advanced itself forward without your control to keep it aligned with the lumen. And so the scope is trying to straighten itself out. It's trying to get back in a straight orientation that it wants to be, but it's not lined up right because you couldn't control it and you couldn't line it up with the lumen. So if that's the case, you have to pull your hand back to undo whatever is propelling the scope forward before you can get any kind of control. So pull back until you see the lumen. Once you see the lumen, do whatever you need to do with your right hand to undo that inchworm or loop, whatever you had going on, and then try again. And that's a good time to see if you can feel an inchworm where you can advance forward using that skill. Okay, so congratulations. Now you've made it through the hepatic, through the transverse colon, but now you're at the hepatic flexure. This is the part of the colonoscopy that if you're a current fellow or resident learning how to do colonoscopy, you may not have much experience with this half of the colonoscopy. Why? Because most people assume that they should start in the rectum and go until their attending takes it from them. Either they've used up their allotted time or they just get stuck. What happens is you wind up getting stuck in a lot of sigmoid colons or splenic flexures, and you don't get much practice on how to do the end of the colonoscope. So what I'll sometimes do, if I'm with a trainee that's in my endo room for a whole day, I might say for some of the scopes, I might say, hey, listen, why don't I get past the splenic flexure? And on this one, why don't you practice the second half of the colonoscopy? Let me just get you past the part that you've done a lot already, and now focus on hepatic flexure and right colon. If you do that, chances are you'll be happy because you'll get to practice an area that oftentimes you don't make it to. So when you get to the hepatic flexure, there's another set of tools to think about. As opposed to the splenic flexure, which is pretty tightly held in place by the splenocolic ligaments, and we know that from being surgeons, mobilizing the splenic flexure is pretty hard. The hepatic flexure is a little bit different. The hepatic flexure is usually a little bit more mobile. Yes, there are hepatocolic ligaments, but the actual apex of that corner is usually loose, which means that you can move it. And gastroenterologists don't realize that, but we as surgeons know. So what I'll do, if I'm having trouble seeing that lumen, sometimes it's easy, right? Sometimes you can see where it turns and you just turn the corner and go. But if you ever are in that situation where you can't see where the turn is, or you think you're in the cecum because you are like, well, there's nowhere else to go, so this must be cecum. Wrong. There is a hepatic flexure. It's just like a slit somewhere and you got to find it. What I try to do is I try to open it up by doing the hook and pull maneuver. So you try to go around the corner with your scope, peek down, go maximally deflected down like this, turn this into a hook, and then pull back towards yourself. And by doing that, by using it like a hook, you can pull it open just enough so that you can then see where you're supposed to go. Then once you pull back like this, you then straighten out your scope and then you can advance forward. So you use it almost like a grabber, like a grasper to open it up and then go forward. Once you're in the ascending colon, this can sometimes be the hardest part of the colonoscopy. And I say this often, the last 10 centimeters of getting across that finish line to make it into the cecum can sometimes be the most frustrating. There's a couple of things that you can try to do here. Number one, decompress the right colon. Just like the transverse colon, the right colon will become overinflated by the insufflation that you're using as you're trying to get up into the right colon. So the first thing I do once I turn that corner and I'm staring down the ascending colon, I'll tap, 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 just like I did around the splenic flexure, because it'll be easier to advance. You want to move slowly here because there's so much scope inside the body that it would be very easy for your forward movements with your right hand to be translated into a loop rather than advancement of the scope. And sometimes all you need to do is move your hand very slowly and it will get it to go forward. If that's not working, then I might ask for pressure. And the pressure that I'll ask for here is transverse colon pressure, not sigmoid colon pressure. I'll always ask for transverse first because chances are your loop is going to happen in the transverse colon. It may happen in the sigmoid colon. So if transverse isn't working, you can try to ask for left lower quadrant pressure. But if someone has a very redundant colon, chances are the problem's not going to be in the left lower quadrant because that's probably not where their sigmoid is. Their sigmoid could be all the way up in the right upper quadrant by the gallbladder. That's why it was such a hard colonoscopy. So again, think like a surgeon. We know where the colon actually is located in these people. We've all seen cecums in the left upper quadrant and sigmoids in the right upper quadrant, right? So don't automatically say, can I get sigmoid pressure? And then the nurses just put pressure in the left lower quadrant, because that's probably not going to be the place that's going to help you if you're stuck in the right colon. This is where prone positioning might help as well. So you might want to ask to put the patient prone. I wouldn't do that with propofol. That's not super safe, but with moderate sedation, it's a good option. So I have a little bit of a pet peeve with pressure because a lot of novice endoscopists, this is the only tool they really know. If they're stuck, they just ask for pressure. The first thing that comes to their mind is, let me ask for pressure. That might help me. And same goes for the endoscopy nurses and techs too. If I'm in endo, I might be having a heck of a time getting around a very difficult splenic flexure, for example, or getting through a really gnarly sigmoid colon. And if they see that I'm struggling, a very well-meaning, well-intentioned endoscopy tech or nurse will say, oh, Dr. Kleiman, would you like some pressure? And I just think to myself, I just say, no, thanks. But I'm thinking to myself, no, that's not the problem. Pressure is not going to help me here. It's not always the right tool to take out. But sometimes it is. And the key is to know when to ask for pressure. So pressure is almost never going to help you proximal to the splenic flexure. It's really only a tool that I'll ask for if I'm in the transverse colon or the right colon. If I'm in the transverse colon, I ask for sigmoid pressure. If I'm in the ascending colon, I'll ask for transverse pressure. Sometimes you need to ask for both. And those are the really hard ones where I'll actually get the tech and the nurse involved to put four-handed pressure on the belly and let them adjust their hands a little bit. To tell them if you feel it somewhere else, feel free to adjust your hands, because a really skilled assistant can really, really help you here. All right, so now let's just talk about how should colonoscopy fit into your practice. So there's a couple of principles here. So the first question that we love to ask our medical students or junior residents, what percentage of colorectal surgery should have a CO2 colonoscope available in the operating room? And in our practice and where I trained, the answer was an emphatic 100%. We should always have a CO2 colonoscope available. We may not always use it, but we always have the right and the ability to ask for one if needed. Gastroenterologists should not be telling you where to cut. You don't want to rely on them to tell you where the colon starts looking healthy. When you're in the operating room and you're making a decision on margins, especially for something like colitis or Crohn's disease, where you're not just automatically taking the whole colon, but where you're trying to do something less, you want to be able to see it for yourself to decide if you're dividing in a healthy place. And then, of course, it's the old Peter Marcello. Actually, I think it's Ronald Reagan, but Peter Marcello loves saying this: trust but verify. He'll scope every single person at the beginning because he doesn't trust anyone else's colonoscope. I'm more selective. I don't do it blanket for everybody. But I have a low threshold to scope myself, especially if it's something like, where's the cancer? You want to make sure you're getting it right. So key components to having a successful and endoscopic colorectal practice: you got to advocate for a CO2 colonoscope in your OR. You should advocate for flexible sigmoidoscopies in your clinic. I'm a big fan of having dedicated endoscopy block time. That way, not only do you build up your skills, but you have the ability to do colonoscopies on your own patients. So if you can advocate for that in your job offer, or as many of you are probably in the process of contract negotiations now or very soon, something to think about working that into your contract. And then, think about whether you want to do just random colonoscopies and just screening colonoscopies. I do. And I think it's a really nice aspect of my practice that just lets me keep my skills up. So we are huge fans of office-based flexible sigmoidoscopies. I understand that this is a luxury that not everybody has, and we have to remind our fellows that they're very, very lucky to have this in their as part of their training. I had it in my training. To me, it's almost a given, but I know that it's not. I know that this is a luxury that we're lucky to have, and a lot of people don't. But for me to think about my practice without it is almost unthinkable. There's no way I'd be able to do what we do in our office without a flexible sigmoidoscopy capability. So, this is just a partial list of things that we do flex sigs for in the office. You see a new rectal cancer patient. We're not doing rigid proctos, blowing up with a thing, looking at a scope. No, we're doing a flex sig so we can actually see it for ourselves and really understand what the luminal dimension is. Look at the association with the rectal folds, really know precisely where that tumor is located. We do a lot of watch and wait in our practice. So these patients come in every 3 to 4 months for 2 years for a flexible sigmoidoscopy in the office. If we didn't have that and we had to bring them to endo every time we do a flex sig, that's an incredible amount of resources that you're being spent to do every watch and wait patient. But for us, it's no big deal. Just come to my office. I'll stick a scope in. We'll look at it, make sure you still look good. All right, you're good. Thumbs up, off, on your way. And then surveillance for rectal polyps. So if I do a lot of, rectal polyp resections with either transanal excision or TAMIS, these patients, depending on what the pathology was, I'll bring them to my office all the time for their surveillances. I'll see them for 3-month surveillance. And then, if it was a cancer, every 3 to 4 months if we're doing local excision for an early invasive cancer. But it's not just that. Those are kind of the obvious ones, but these are other things we do. If I see an FAP patient, a question that everybody should ask themselves is this rectal sparing FAP? Does this patient with FAP have rectal sparing and have an option for an ileorectal? Or does this patient need a proctectomy and need a J pouch? Well, easy. If the endoscopy report doesn't specify, look for yourself. Every FAP patient that I see in the office gets a flex sig so I can see how many polyps are in the rectum. Patient with an anastomotic leak, you think they may have a leak? We're very lucky because our clinic is right in the same building as the inpatient unit. So we wheel patients over to our clinics all the time that are inpatients, and we just do a quick flex sig. Nothing to do with the endoscopy unit. Let's say you have an IBD patient considering surgery, and I don't know what the rectum looks like. I want to figure out what kind of landing strip am I going to have in terms of the possibility of a segmental resection, or do they need a total proctocolectomy? You can do that right in your office. We see inpatient consults for rectal bleeding, and we get called for a hemorrhoid. If it's during the day, during the week, I say, hey, we're lucky. It's during the day, during the week. Bring them over to clinic. Let's do a flex sig and an anoscopy, and we'll just figure this out right now. Intraoperative colonoscopy is another incredibly valuable tool that I hope you all have the opportunity to get in your practice. You can do everything that I did before. So let's say it's after hours on a weekend, and I think I might have a leak or something, and I don't want to call in the endo unit. We'll sometimes bring patients to the OR just to do a scope. We'll do it sometimes. We try not to, but sometimes we do. That scenario I gave at the beginning where you can't find the tattoo, that's happened to me. No problem. Let's do a scope. You don't have to be calling GI to wheel a tower in. No, you got it right there. Assessing your margins. I do a scope before every distal transection for diverticulitis because I want to make sure that I'm not leaving any diverticulum behind. So I use a scope before I divide. And then there's the really fun stuff, like the stuff that we do with combined endoscopic laparoscopic cases. So this is how we remove appendiceal orifice polyps. I think a more common thing is if you have a polyp at the appendiceal orifice, take the appendix with a little cup of sebum, open up the specimen, hope that you had it, and then be on your way. But we like to be a little bit more sophisticated with that. So we'll do simultaneous colonoscopy and endoscopy. So that's me between the patient's legs doing a colonoscopy while someone is doing the laparoscopic part. And I was trying to figure out who this was, and I couldn't. But this is from a couple of years ago. So my fellow and a resident are at the bedside doing the laparoscopy while I'm below between the legs doing a colonoscopy, and we split the inputs on our screens. So the screen on our left is a colonoscopy, and the two screens on the right are the laparoscopic view. And we sit there, and I watch from the inside as the fellow is closing the stapler on the cecum and make sure that we're taking enough and make sure that the polyp is gone. And that's just a really, really fun way of using these technologies in harmony to really do some pretty cool stuff. So just to kind of drive the point home about how integral colonoscopy is in my life, this is my typical week. And every day that I'm using a colonoscope has a little picture of a colonoscope next to it. So on Monday is my full day in the endo suite. I typically do somewhere between 10 and 12 colonoscopies every Monday. And obviously I'm scoping then all day. Tuesday and Wednesday are my OR days, and I've got a scope available in every single case. Some of them are dedicated endo procedures, like a double channel EMR. Others are just part of the operation. Thursday is sort of a potpourri. Sometimes I'm admin. Sometimes I go up to our satellite facility and do a half day of endo and then clinic. So I'm doing more colonoscopies there. And then Friday is my all-day clinic day. And on a typical clinic schedule, I'll usually do about 5 flexible sigmoidoscopies per clinic. So there's literally not a day that goes by in my practice where I don't have a scope in my hand at some point, which just kind of goes to show how important it is for us to do what we do. So I'm making it sound all nice and easy and okay, this is great. What a wonderful situation we have. Well, there's barriers and you're going to run into this. And a lot of you, might be lucky in where you're training, but you're about to enter the real world where this may not be your reality. So I realize that. And this is where, you have to use your power of negotiation, because I think a lot of these, there are ways around it. And if we can be of any help to kind of give you ideas on how to do that, we'd be happy to. But the biggest barrier, obviously, is money. One endoscopy tower with flexible sigmoidoscopy capability in your clinic that's probably the biggest cost barrier for a lot of people, especially if their clinic is not in the main building of the hospital like ours is, but if it's off-site somewhere, it's a challenge, and it's a costly challenge. Along those lines, infrastructure may not support this. So that's a big issue for a lot of people that are in an office building, and that's where their clinics are. How are they going to figure out how to process these scopes and get them clean? So it's just not feasible for them. And then there's the political stuff. So, it's working out the local politics with your GI department and your endoscopy schedule. We're very lucky that at Lahey, there's a long tradition of colorectal. So there's a lot of precedent for us having a major presence in endoscopy, but that's not the case everywhere. I know where I trained, it certainly wasn't. So that can be a challenge. But again, there's ways of working around that, because at the end of the day, the gastroenterologists don't really want to be called to do intraoperative consults in the operating room. They're very uncomfortable in that situation, in that setting. And so there's a lot of ways to approach this to work out those politics. So in summary, colonoscopy is hard. There's no way around it. You've picked a difficult field to master, and it's going to take you a long time to get there. But you should feel confident knowing that you can set yourself up for success by thinking about the right scope, the right sedation, the right position, and go into your endoscopy suite with your toolkit and try filling up your toolkit with as many tools as you can. Hopefully tonight started your primer, your starter toolkit if it hasn't been started yet. But I'm sure you all have a toolkit already. Hopefully we can add to it and then keep building to it as you finish your training and start your practice. Remember, a straight scope is a happy scope. Reduce early, reduce often. Try to get yourself back to a good workable position. Work on getting 24/7 access to colonoscopy in the OR. Push for getting flex sigs in the clinic, and try to convince your administration and your gastroenterologist that if you do this, it will lead for better, cheaper, and more streamlined care in the long run. I'd like to thank Peter Marcello. He gave me some of the images, some of the cartoons from this came from old talks of his, so thank you. And once again, thank you to the virtual education series and Sir John for inviting me to be here.
Awesome. Thank you, Dr. Kleiman, for that absolutely awesome talk. I have a bunch of questions here for you if you have a moment.
Sure.
So we'll go ahead and fire away here.
Yeah.
And on Sir John, we have a couple here as well. So in no particular order, what are your feelings about 2 versus 1 hand on the scope at all times? Are you okay with taking your hand off the scope to do the dials?
I would be cute and ask you what my answer to that is, since we've talked about that many times, but I'll keep you off the hook. You're here the host, not as my fellow. I have size 7.5 hands, and I understand that not everybody does. And if you have smaller hands and if you have intrinsic hand strength, limitations, you're not always going to be able to be a one-handed endoscopist. So I fully acknowledge that there are many, many people that have to be comfortable doing two hands on the dials. That being said, there are many, many people who use two hands that don't need to. Even people with small hands, there are ways of holding the scope to maximize your reach. For example, I don't have a dial to be holding to do this, but many people hold it like they're holding like a gun, sort of, or like I don't know what a better analogy is, but it's fully in their palm. Whereas when I'm holding a scope, I'm really holding it with my fingertips. It's resting in between my thumb and my middle finger, but my palm is nowhere near the scope, and I'm using my thumb by the tips, and I'm using these fingers by the tips, so you can position your hand so that you can actually reach a lot farther. I think some people think their hands are too small to be one-handed because their hand's too locked on the scope. So I would encourage you to try that first before bringing your right hand over. If you do bring your right hand over, the word of warning is don't get lube on the dials. If your right hand is covered with lube and then you bring that lube over to the dials, you're going to be miserable because it's going to make it way harder to control the scope. It's going to slide everywhere. So if you're a two-handed endoscopist, just keep your hand far away from the anus and don't let it get covered in the lube that's coating the scope and like that perianal skin, because that's where you're going to really run into some trouble.
Awesome. What trick do you use to keep the sigmoid from constantly collapsing while trying to remove a polyp?
Oh, good question. So, hopefully you all have access to CO2 and not air. If you have access to CO2, then you can be extremely liberal in your use of insufflation. And there's a spectrum of opinions on that. Even among my partners, I know some of my partners are minimalists with their insufflation. I'm probably a maximalist, and it makes our fellows feel like they're all over the place. They don't know what to do, as Gabby's tucking because they just have to remind themselves of what day it is and who they're scoping with. But I have my finger on the insufflation almost the entire time, especially if I'm trying to take out a polyp. And especially if you're trying to use suction. And that's the other thing. I didn't really go into the details of suctioning, but it's incredibly important to be a precise suctioner. We call it precision suctioning. You have to know where the suction channels are and how to use it appropriately. So if you're trying to suction out a puddle, and if that suction is in the puddle, in the right depth of the puddle, you'll suction the puddle without collapsing the colon and without creating a suction polyp on the mucosa if you're too deep. But if you're suctioning in the middle of the lumen and you're holding down that suction, then the whole wall is going to collapse down around you. So you have to be precise with your suction and hold the insufflation the whole time. And if you do those two things, you're going to keep a nice, stable view as you're working on a polyp.
All right. Talking about polyps, and as many of us have oral boards coming up, can you talk about your algorithm for how to remove different polyps of different types and sizes, namely a hot, cold snare, hot, cold forceps?
Yeah, that's a big question that I'll make a quick answer to. So I think in general, as a surgeon, we're more comfortable burning the colon than gastroenterologists are. So beyond a doubt, I use a lot more hot snare than the gastroenterologists do. But you have to use it intelligently, and you have to understand what you can and can't do, and how much burning is too much and how deep is too deep. So, I would say early on, err on the side of cold snare until you get more comfortable with hot snare. But if it's a cost thing, cold snare and a clip costs more than hot snare and no clip. A clip is about $430 per clip. So remember that as you're cold snaring off polyps that are then bleeding, and then you're asking for a couple of clips for. You may have been better off just using a Bovie pad and just doing it hot, so you don't have to put clips afterwards. So, it's personal preference and it's just what you're comfortable with. But I do probably, I don't know, maybe 50-50 hot and cold. I also really like the jumbo forceps if you're going to do if it's something small. I love asking for the jumbo forceps versus the regular large forceps. I think you can get bigger bites of those small sessile polyps and somehow less bleeding. And I don't know why it's less bleeding, but I think it is. So I use jumbo forceps a lot too.
Okay. Couple questions about logistics here. It does incubate, but I think we meant intubate the terminal ileum every time. And do you routinely retroflex? Either of those things routine?
Awesome. Great questions. So, in my first year in practice, I decided to myself, I was going to intubate the terminal ileum every time. Why? Because I wanted to get really, really, really good at it. And the only way to get really good at it is to try to do it and force yourself to do it a lot. Once I started to feel like I could do it whenever I needed to, now I don't do it every time. I do it if I feel like I need to, or I'll do it if it's easy. But if I'm having trouble and there's really no reason to, then I don't stress about it. But I would encourage trainees and people new in practice to make a habit of it, because at some point you're going to have a 22-year-old with bloody diarrhea that's put on your endoscopy schedule because someone wants to rule out Crohn's disease. And if you don't intubate the TI to look at the terminal ileum, then you haven't really done the job. And suddenly it's going to be really important. And you don't want to be calling for help to get into the TI. You could feel free to call for help if you need it, but I wanted to build up my comfort with terminal ileal intubation so that I knew I could do it when I needed to. So that's the quick answer about that. Retroflexion, yes, I routinely retroflex in anyone unless they've had an LAR or pelvic radiation. If they've had an LAR or pelvic radiation, then that's a big fat no. If we were in person, I would say raise your hand if you've ever seen a rectal perforation for retroflexion. I have. Thank God it wasn't me that did it, but it was one of the GI fellows in our facility that did it. And gosh, he felt really bad afterwards. So, you can hurt someone. I also, you have to know when it's appropriate. There are some people whose rectums they don't fit those two caveats that I just said, but the rectums are just not big. And I might look at that and be like, oh, you know what? I'm not going to try to retroflex here because there's not actually that much space to retroflex. So don't be afraid not to. You don't have to in every case, but pretty much routinely I would.
Are you able to bill for CO2 colonoscopies intraoperatively?
Yes, you can. However, there's a caveat there about whether you biopsy or not. And we only recently learned this, that if you do a colonoscopy without a biopsy, sometimes it's considered part of the surgery and they can't bill for it. But if you biopsy, meaning remove a small polyp or do anything, then it counts as a procedure that can be added on. So we basically include it as the code, and then the coders figure that out on the back end. And I think sometimes it gets dropped. And I'm probably not the most up on the nuances there to give the most precise answer, but that's my understanding. And actually, Marcelo, this was news to him about a year ago too, and I would have thought he would have known that, but that was surprising news to all of us.
Any comments? There's a question here about pulling back the scope, about rotating clockwise and pulling back the scope. I think that may refer to withdrawal of the scope, I think. But any comments or questions or tips about scope withdrawal as opposed to advancing scope?
Yeah, sure. So yeah, I didn't talk too much about withdrawal, but that's another skill set. Basically, you have to use a lot of right hand on a withdrawal, because you're pulling back, but your right hand should be doing a lot of turning left and right. You really want to think of your head kind of on a swivel as you're withdrawing, and you're kind of looking everywhere around all the nooks and crannies. So it should be a very dynamic process. And so my left hand is maybe a little bit less active on the withdrawal, just because you can't go up, down, left, right to that sharp of angles all at the same time. So I use my right hand to help me with that. And it's not just a clockwise turn. It would be clockwise or counterclockwise. It's basically whatever you want to do to be able to kind of like move your head all around as you're pulling back. In terms of if that question was about loop reduction, then it's almost always a clockwise rotation, but sometimes it's not. I mean, the colons can take all kinds of bizarre twists and turns. And sometimes you might feel that the corkscrew is going in the other direction, and I might rotate counterclockwise to get it to feel straight. Whatever you have to do to get the scope straight, you do. Usually it's clockwise, but sometimes it's going to be counterclockwise.
All right. And I've got one last question here, which is about who cleans the scopes for the flex SIGs in clinic? Do they get transported to endo to be officially cleaned?
Yeah, good question. So yes, again, we are logistically very lucky at Lahey because our clinic is on 6 West and endoscopy is 2 West, and it's the same building. So our MAs run the scopes downstairs after we use them, and they run them down and they get processed in endo. We're about to get even luckier because they're about to open I don't know, Gabby, if you even know this, but they're opening the IBD center, which is literally right next to our clinics, and they have a scope processing center right there in the IBD center. So within a month, we don't even have to go downstairs anymore. They're going to get processed right next door because the IBD center is going to include a scope processing center. But we're lucky. I'll tell you, when I was at Cornell, the colorectal clinics were across the street in the Greenberg Pavilion, the Moynihan Center across the street from the main hospital. And what I remember is they had flex SIGs there, but it was in a different building. They basically had someone that, like, at the beginning of the day brought a whole cart over with scopes, and then at the end of the day brought the cart back to the main hospital, almost on like a cart that was almost like what the cafeteria people do to deliver lunches. It was like on one of those big rolling carts. And they just did that in the morning and evening. So it was a little bit harder, but they figured out a way to do it.
Awesome. All right. Well, thank you very much, Dr. Kleiman, for the talk, and everybody for the awesome questions and feedback. We really appreciate everybody's participation. And for anybody looking to check out our website, it's crsvirtualed.org. Please join us next week, February 4th, for our talk on difficult stoma management. Thanks again, everybody. Have a good night.
Thank you. Take care, everyone.